Good day, everyone. Today, we'll be diving into the essential topics of IV therapy and blood transfusion. Let's start by outlining our learning outcomes. By the end of our discussion, you should be able to collect assessment data related to clients' fluid, electrolyte, and acid-base balances, explain rationale and procedures for initiating an intravenous line, maintaining the system, changing intravenous solution containers, tubing, and dressings, and discontinuing peripheral venous access. Discuss the procedure for initiating and monitoring a blood transfusion and the appropriate nursing actions to take if transfusion reactions occur. Evaluate the effective nursing and collaborative interventions on clients' fluid, electrolyte, or acid-base balance. And lastly, demonstrate appropriate documentation and reporting of fluid, electrolyte of fluid acid-base balance activities. Now let's take a look at the definition of IV therapy and how it works. Intravenous IV therapy involves injecting substances directly into a vein. It's a rapid method for administering fluids, electrolytes, and medications, and is commonly used in hospitals. Around 80% of patients will require it. However, it's invasive, so aseptic techniques are a must. Intravenous fluids, also called intravenous solutions, are supplemental fluids used in intravenous therapy to restore or maintain proper fluid volume and electrolyte balance when oral intake is not feasible. This therapy is an efficient method for delivering fluids directly into the bloodstream, replacing lost electrolytes, and administering medications or blood products. There are 3 types of IV solutions. These are hypertonic, isotonic, and hypotonic. Isotonic solutions are solutions with the same concentration of solutes as blood plasma. These fluids are used to restore or expand vascular volume without causing a fluid shift between compartments. The examples are 0.9% sodium chloride, often used for fluid resuscitation in hypovolemia, shock, or dehydration, can be administered with blood transfusions as it doesn't cause hemolysis. Lactated ringers contains balanced electrolytes, sodium, potassium, calcium, and lactate, and is ideal for surgical or burn patients. Used for correcting metabolic acidosis due to the lactate metabolizing into bicarbonate. 5% dextrose in water, initially isotonic but becomes hypotonic when dextrose is metabolized, used to provide free water and energy while avoiding solute overload. Hypertonic solutions are solutions with a higher solute concentration than blood plasma. They draw water out of cells into the extracellular space, which can reduce swelling or edema. Effective in treating cerebral edema and increased intracranial pressure. Also, it is used cautiously due to the risk of cellular dehydration. The examples are 5% dextrose in normal saline, used in cases of severe dehydration or to replace sodium and chloride losses. 5% dextrose in 0.45% sodium chloride, commonly used to maintain fluid and electrolyte balance. And 5% dextrose in lactated ringers combines the benefits of dextrose and electrolyte replenishment, useful in post-surgical recovery. Hypotonic solutions are solutions with a lower solute concentration than blood plasma. These fluids move water from the extracellular fluid, ECF, into the intracellular fluid, ICF, hydrating cells. It is primarily for patients with dehydration or hypertonic states, such as diabetic ketoacidosis after initial stabilization. Avoid giving patients with increased intracranial pressure or risk of cellular swelling. The examples are 0.45% sodium chloride, half normal saline, and 0.33% sodium chloride, 1/3 normal saline, which provides a more diluted saline option for mild cases of dehydration or hypernatremia. Now, let's talk about the purpose of intravenous therapy and why it is important. The purpose of IV therapy is to supply fluid when clients are unable to take an adequate volume of fluids by mouth, provide salt/electrolytes needed to maintain electrolyte imbalance, provide glucose, called dextrose, the main fuel for metabolism, and provide water-soluble vitamins and medications. Indications for IV therapy are the following: repeated blood sampling, IV administration of fluid, medications, chemotherapeutic agents, IV nutritional support, IV administration of blood or blood products, and radiologic contrast agents for computed tomography, CT, magnetic resonance imaging, MRI, or nuclear imaging. There are no absolute contraindications for IV cannulation. However, peripheral venous access in an injured, infected, or burned extremity should be avoided if possible. Continuing the discussion, let's elaborate on the essential reminders we should do and consider when performing IV therapy. For the assessment, the nurse should obtain and monitor vital signs for baseline data, assess allergy to latex, tape, or iodine, check for bleeding tendencies, disease or injury to extremities, and the status of veins to determine the appropriate vascular access site. Remember to avoid sites that have been used recently, because recently used sites will be more prone to complications and discomfort. The nurse should also determine whether the client is right-handed or left-handed. As much as possible, do not use the dominant hand so that the patient can still perform simple functions using that hand. Avoid blind venipuncture and use a vascular visualization method to prevent complications. Remember also that shaving is not recommended because of the possibility of nicking the skin and subsequent infection. In planning, the nurse should prepare the client by discussing why the IV is needed, addressing patient concerns, and obtaining informed consent. The nurse should check for allergies, previous IV complications, ongoing medications, and conditions that affect venous access like dehydration or edema. It includes considering having local anesthesia agents to reduce the pain and discomfort of catheter insertion. The nurse should also be aware of factors that affect the choice of vein and catheter size. When identifying a suitable vein, consider the patient's condition, vein quality, and infusion requirements. The most common sites are the hands, forearms, and antecubital fossa. Remember the importance of considering how long the patient will likely have the IV transfusion. Identify the kinds of fluids that will be infused and the medications the patient will be receiving or is likely to receive. Preparing the equipment, the nurse should gather all the necessary supplies to perform IV therapy. The equipment includes an infusion set, sterile parenteral solution, IV poles, non-allergenic tape, clean gloves, sterile gloves for site palpations after skin antisepsis, and single-use and latex-free tourniquet. Antiseptic swabs, 10% povidone iodine or 2% chlorhexidine gluconate with alcohol or 70% isopropyl alcohol, an IV catheter, a vein visualization device that projects a real-time image of a patient's veins onto their skin surface, and sterile gauze dressing are also essential equipment during IV therapy. IV cannulas are differentiated by gauge sizes, determining their outer diameter, flow rates, and suitability for various medical applications. Here's an overview based on typical standards. The 14-gauge orange IV cannula has an outer diameter of 2.1 millimeters and an ideal flow rate of 240 milliliters per minute. It is commonly used for emergencies requiring rapid fluid or blood replacement. The 16-gauge gray IV cannula has an ideal flow rate of 1.8 milliliters per minute. It is commonly used for trauma patients, surgeries, and blood transfusions. The 18-gauge green IV cannula has an outer diameter of 1.2 millimeters and an ideal flow rate of 90 milliliters per minute. It is commonly used in blood transfusions, IV fluids, and pre-surgical preparations. The 20-gauge pink IV cannula has an outer diameter of 1.0 millimeters and an ideal flow rate of 60 milliliters per minute. It is commonly used in routine infusions, medications, and blood sampling. The 22-gauge blue IV cannula has an outer diameter of 0.8 millimeters and an ideal flow rate of 36 milliliters per minute. It is commonly used for pediatric and elderly patients with fragile veins. The 24-gauge yellow IV cannula has an outer diameter of 0.6 millimeters and an ideal flow rate of 20 milliliters per minute. It is commonly used for neonatal, pediatric, or very fragile veins. IV cannulas are categorized based on their design, material, and intended use. We have the closed Y type, which is often used in blood transfusions and situations requiring a simultaneous or sequential infusion of two different fluids. The gauge size of a closed Y-type IV cannula typically ranges between 16-gauge and 20-gauge, depending on its purpose and the clinical scenario. Next, we have an open-type IV cannula with butterfly wings, commonly referred to as a butterfly needle or winged infusion set. It is widely used for short-term intravenous access due to its convenience and precision. Its gauge size typically ranges from 18-gauge to 24-gauge, depending on the intended use and patient requirements. An open-type IV cannula with an injection port is a type of IV device that includes an additional port for injecting medications or fluids without needing to disconnect the primary infusion line. This design provides flexibility and reduces the risk of contamination. The gauge size for an open-type IV cannula with an injection port typically ranges from 18-gauge to 24-gauge. We also have the pen-type IV cannula, a specific intravenous cannula design known for its pen-like shape and streamlined functionality. It is primarily used for intravenous access in clinical and emergency settings. This type of cannula is favored for its simplicity and ease of insertion. Like other IV cannulas, it is available in various gauge sizes depending on the intended use and the patient's needs. Remember that the nurse should check the IV solution, ensure the correct type, volume, and expiration date, and inspect the solution for clarity and contamination. In preparing the IV solution and tubing, it is essential to prime the IV tubing to prevent air bubbles and ensure that the flow rate is appropriate. Since we have enough knowledge regarding IV therapy, let's discuss how to properly implement the step-by-step process of preparing the IV line. The first step a nurse should do is to verify the doctor's order. Verifying the doctor's order ensures that the procedure is authorized, accurate, and aligns with the prescribed treatment plan. This step prevents errors such as administering the wrong therapy, dosage, or medication, ensuring patient safety and adherence to professional standards. Next is to assess the patient's vital signs, bleeding tendencies, disease or injury to extremities, and status of veins. Assessing vital signs provides baseline data to detect any abnormalities or contraindications for IV therapy. Checking for bleeding tendencies ensures patient safety, especially in cases where anticoagulants or coagulopathies might increase the risk of complications. Evaluating the condition of extremities and vein status helps determine the best site for IV insertion and avoids injured or compromised areas, such as those affected by trauma, infection, or complications. The nurse should also determine if the client is right or left-handed. Knowing whether the patient is right or left-handed allows the nurse to choose an IV site on the less dominant hand or arm. This minimizes interference with daily activities and reduces the likelihood of accidental dislodgement or discomfort during movement. For effective communication and patient cooperation, the nurse should introduce themselves and verify the client's identity using agency protocol to ensure that the correct patient receives the intended care, reducing the risk of medical errors. Explaining the procedure and its purpose helps reduce the client's anxiety, ensures informed consent, and encourages active participation in the process. After that, the nurse should perform hand hygiene. It reduces the risk of introducing pathogens to the patient during the procedure, which ensures a safe and sterile environment for IV insertion. Assisting the client to a comfortable position, sitting or lying, minimizes discomfort, and allows easier access to the chosen site for IV insertion. Expose the limb to ensure proper visibility of the veins while maintaining privacy, which respects the patient's dignity and comfort. Open and prepare infusion set. When opening and preparing the infusion set, remove tubing from package and straighten it out. Then, slide tubing clamp along the tubing until it is just below the drip chamber to facilitate its access. Close clamp. Then leave ends of the tubing covered with plastic caps until the infusion is started to maintain sterility of ends of tubing. After that, spike the solution container and hang it on a pole. When spiking the solution container, expose insertion site of bag by removing protective cover. Then, remove cap from spike and insert spike into insertion site of the bag. When hanging the solution container on pole, adjust pole so container is suspended about 1 meter or 3 feet above client's head. By doing that, it enables gravity to overcome venous pressure and facilitate flow of solution to vein. The nurse should ensure that they partially fill the drip chamber with solution. Squeeze the chamber gently until it is half full of solution. Partially dripping the drip chamber with solution prevents air from moving down the tubing. Next is to describe prime tubing. Prime means to make ready, but in common use refers to flushing tubing to remove air. Remove protective cap and hold tubing over container. Maintain sterility of end of tubing and cap. Now, the nurse can release the clamp and let the fluid run through the tubing until all bubbles are gone or removed. To help the bubble move, tap tubing if necessary using your fingers. Priming the tube prevents air and air bubbles, smaller than 0.5 liters, usually do not cause problems in peripheral lines. Do not forget to reclamp tubing and replace tubing cap while maintaining the sterile technique. And lastly, perform hand hygiene again prior to client contact to reduce the risk of cross-contamination, sustaining the principle of infection control and patient safety. Next, let's talk about how to safely and effectively insert an IV. First is to select a suitable venipuncture site. Consider using the client's non-dominant hand, unless if it is contraindicated. It is contraindicated to patients with mastectomy, since there is a damage to blood vessels leading to fluid buildup and swelling in the arm, which can potentially harm them and increase their risk of having complications such as lymphedema, infection, and impaired circulation. Also contraindicated to patients with fistula because it can lead to thrombosis, damaging the fistula and increasing the risk of infection. The nurse should select veins that are relatively straight to make the venipuncture process easier and more successful, as straight veins allow for smoother needle insertion and reduce the risk of damaging the vein. Veins should look palpable, but may not be visible, especially in dark skin. Remember to not just look into it, but ensure that it can be felt, so that it can help you locate the vein accurately. Consider catheter length. Look for sites sufficiently distal to wrist or elbow such that tip of catheter will not be at point of flexion. The reason for this is sclerotic veins may make initiating IV difficult, since joint flexion increases risk of irritation of vein walls by catheter. It could also reduce the risk of dislodgement and improve better patient comfort and mobility. Second is to dilate vein. When dilating the vein, the nurse should place extremity-independent position lower than client's heart. It is because gravity slows venous return and distends vein. Distending veins makes it easier to insert the needle. The nurse should apply a tourniquet 15 to 20 centimeters or 6 to 8 inches above venipuncture site. Because a tourniquet must be tight enough to obstruct venous flow, but not so tight that it occludes arterial flow. Note that obstructing arterial flow inhibits venous filling. If a radial pulse can be palpated, it means that arterial flow is not obstructed. Remember to use a tourniquet on only one client to avoid cross-contamination to other clients. Don't forget to ask if client has latex allergy to avoid triggering serious allergic reactions, ensuring that all materials and products used are safe for the individual. What should the nurse do if the vein is not sufficiently dilated? The nurse should massage or stroke the vein distal to site and in direction of venous flow towards the heart, which helps to fill the vein. Instruct the client to clench and unclench fist, because contracting the muscles compresses distal veins, forcing the blood along veins and distending them, which promotes venous return and improves circulation. Also, lightly tap vein with fingertips, because tapping may distend the vein. If preceding steps fail, remove tourniquet and wrap extremity in warm towel for 10 to 15 minutes. The heat dilates superficial blood vessels, causing them to fill. After that, repeat steps to dilate vein. Note, if no venous site are visible or easily palpated, the nurse can use vein visualization technology to improve insertion success. After dilating the vein, remove tourniquet while preparing the insertion site. Apply clean gloves to clean venipuncture site, protecting the nurse from contamination caused by the patient's blood. Remember to clean skin with soap and water if it is visibly soiled, and don't forget to remove excess hair using scissors or surgical clippers. Clean skin at site of entry with topical single-use antiseptic swab. Antiseptic is chlorhexidine gluconate alcohol solution, which is commonly preferred antiseptic. Check if the patient is allergic to iodine or shellfish before cleansing the skin with betadine or iodine solution. Before we proceed, here are some of the cleaning techniques we can use to clean insertion site. First is to apply antiseptic in a circular motion, starting from the cleanest area, which is puncture or incision point, and move outward to the periphery. Note: avoid reapplying the same compress to any area to prevent recontamination. Next is back and forth technique. To do this, move around the insertion point and ensure antiseptic reaches and impregnates cracks and crevices. In chlorhexidine solution, use back and forth motion for 30 seconds to scrub insertion area. Allow completely air dry before inserting. Note: do not fan or blow on or wipe skin, because this action can contaminate the clean area, compromise the sterility, and introduce bacteria. Povidone iodine, used with an appropriate applicator, and should remain on skin for 1.5 to 2 minutes, or longer to completely dry for adequate antisepsis and effective microbial reduction. Alcohol should not be applied after povidone iodine because it counteracts effects of povidone iodine. After cleaning the venipuncture site, reapply tourniquet above intended site. If vein palpation is necessary after application of skin antiseptic, use sterile gloves. Next is to insert catheter and initiate infusion. Remove catheter first from its sterile packaging, then remove the cover of the needle. Use non-dominant hand to pull the skin taut below entry site. This helps stabilize the vein, prevents movement, and makes the skin tighter, which can minimize pain when the needle is first introduced into the tissue. The nurse should hold over the needle catheter at 15 to 30 degree angle with the needle bevel facing up during insertion, then insert catheter through skin and into vein. You should feel a lack of resistance once the needle enters the vein. The catheter should be inserted slowly and steadily with controlled motion. It's important to avoid any jerky or forceful motions, such as jabbing or stabbing, which could cause damage to the vein or surrounding tissue. Once the needle is inside the vein, you should see blood appear in the needle's lumen, the hollow tube, or the flashback chamber. This is a visual confirmation that you have successfully entered the vein. You reduce the angle of the needle, bringing it closer to being parallel with the skin, often around 5 to 15 degrees. This step is important because the catheter needs to be advanced into the vein in a straight line, not at an angle, to ensure it is placed properly. After adjusting the needle's angle, you advance both the needle and the catheter together, typically by about 1.5 to 1 cm, or roughly 1/4 inch. This step ensures that the catheter, not just the needle, is inside the vein. If there is no blood return, try redirecting the catheter again towards the vein. If the stylet has been withdrawn from the catheter even a small distance, or the catheter tip has been pulled out of the skin during the insertion process, even if the stylet is still inside, the catheter must be discarded. Note: reinserting the stylet into the catheter can result in damage or slicing. The catheter removed from the skin should never be reused because it is already contaminated. Carefully remove stylet and attach the end of the infusion tubing to the catheter hub. Do not forget to place the stylet directly into Sharp's container. Next is to initiate infusion or to flush the catheter with sterile, normal saline. Blood must be removed from catheter lumen and tubing immediately because it will clot inside the lumen. Remember to watch closely for any signs of the catheter infiltration, because infiltration or inflammation requires the removal of the IV catheter to avoid further trauma to tissue. Next, release the tourniquet, then put pressure on vein proximal to the catheter to eliminate or reduce blood oozing out of the catheter. The nurse should stabilize the hub using their thumb and index finger of non-dominant hand. Remember to remove protective cap from distal end of tubing and hold it ready to attach to the catheter, maintaining sterility of the end. Stabilize catheter hub and apply pressure distal to catheter with your finger to prevent excessive blood flow through the catheter. After inserting the catheter and initiating the infusion, stabilize catheter and apply dressing. Do not forget to secure the catheter. If tape is used, it must be sterile tape or surgical strips, and they should be applied only to the catheter adapter and not placed directly on catheter skin junction site. Most importantly, do not forget to put a label to the dressing. The label should consist of date and time of insertion, size of the catheter, and your initials. Also, remember to loop the tubing and secure it with tape. Looping and securing the tubing prevents its weight or any movement from pulling the needle or the catheter. For further understanding, these are the images on how to properly perform the steps from number 6 to number 8. If done, discard tourniquet. Then, remove and discard gloves and perform hand hygiene. The nurse should also ensure appropriate infusion flow by adjusting the infusion rate of flow according to the doctor's order. And lastly, do not forget to label the IV tubing. Again, label tubing with date and time of attachment and your initials to ensure that it is changed at regular intervals. For the evaluation, complete following client teaching after IV infusion. Any limitations as to movement or mobility and protection of sight. And the signs and symptoms that the patient should report to nurse, like pain, swelling, and redness. The nurse should regularly check the client for intended and adverse effects of infusion. It is recommended and essential to check the patient at least every 4 hours. While doing that, you should check skin status of IV site. If there is warmth of the temperature, an absence of pain, redness, or swelling. Also, check for the status of dressing, client's ability to perform self-care activities, and client's understanding of any mobility limitation. For the documentation, the nurse should record the venipuncture on the client's chart, including the date and time of venipuncture. Some agencies provide a special form for this purpose. The nurse should also document the type, length, and gauge of the needle or catheter. It is also important to document the location and condition of the venipuncture site and how many attempts were made. We should also document the name or title of the person who performed the venipuncture. Do not forget to include the amount and type of solution used, and the additives or medications infused during IV therapy, also the flow rate, including the changes in infusion and its duration. Include the type of dressing applied for insertion site care, record the condition of the insertion site, and lastly, the client's general response and client education. documenting the patient's response to the IV infusion, such as any discomfort, pain, or adverse reactions, and post-infusion instructions provided, such as signs of complications to watch for or when to notify healthcare staff. Before proceeding to IV removal, let's first discuss facts about blood transfusion and how we should properly do it. Blood replacement, or transfusion, involves the intravenous administration of whole blood, or its components like plasma, packed red blood cells, platelets, or cryoprecipitate, to treat various medical conditions. These transfusions are essential for patients with severe anemia, significant blood loss, like from surgery or injury, or certain blood disorders that affect blood production or clotting. Packed red blood cells, PRBCs, are used to treat anemia and increase oxygen carrying capacity. Plasma helps in clotting disorders and fluid balance. Platelets are given to patients with low platelet counts to prevent bleeding. Cryoprecipitate provides clotting factors for conditions like hemophilia. Blood transfusions are typically needed in cases of severe blood loss or conditions like leukemia or sickle cell disease. Careful testing for blood compatibility and monitoring during the procedure are crucial to avoid reactions and ensure safety. These are the purposes of blood transfusion: to increase O2 carrying capacity of blood, as in anemia, to replace circulating blood volume, or as volume expansion, WB, for cases of hemorrhage, to prevent bleeding if there's platelet deficiency, and to combat infection if there's a decrease white blood cells. These are the indications for blood transfusion. It is done with patients who will undergo major surgical procedure to replace any blood loss during their surgery, for patients with serious injuries from car crashes or natural disasters, and for patients with illness that causes anemia such as leukemia or kidney disease. Whole blood is not commonly used except for extreme cases of acute hemorrhage. It replaces blood volume in all blood products like RBCs, plasma, plasma proteins, fresh platelets, and other clotting factors. Packed red blood cells, PRBCs, is used to increase the oxygen carrying capacity of blood in anemias, surgeries, and disorders with slow bleeding. The 1 unit of PRBCs has the same amount of oxygen carrying RBCs as a unit of whole blood. However, it raises hematocrit by approximately 2% to 3%. Autologous RBCs is used for blood replacement following planned elective surgery. Client donates blood for autologous transfusion 4 to 5 weeks prior to surgery, while the platelets is used to replace platelets in clients with bleeding disorders or platelet deficiency. Fresh platelets are most effective. Each unit should increase the average adult client's platelet count by about 5,000 platelets per microliter. The fresh frozen plasma provides clotting factors. It does not need to be typed and cross-matched and contains no RBCs. Albumin and plasma protein fraction are blood volume expander, which provides plasma proteins. Last is the clotting factors and cryoprecipitate, which is used for clients with clotting factor deficiencies. Each provides different factors involved in the clotting pathway. Cryoprecipitate also contains fibrinogen. The contraindications for blood transfusion includes patients with religious beliefs like Jehovah's Witnesses, risk of volume overload because they may not tolerate the additional fluid volume from a blood transfusion, which can lead to complications like pulmonary edema. Congestive heart failure because they may be at higher risk of complications due to the extra volume from transfusions, which could worsen heart failure symptoms or cause fluid buildup in the lungs. Infections or risk of bacteremia because it may increase the risk of spreading infection. And aortic stenosis because transfusions can increase blood volume and cardiac workload, potentially leading to cardiac complications like heart failure or arrhythmias. For the assessment, the nurse should assess the vital signs. Oxygen saturation. In physical examination, check the fluid balance and heart-lung sounds because those are related to the manifestations of hypo or hypervolemia. Assess the status of infusion site and patency of vascular access device. The blood test results, especially the hemoglobin value or platelet count, and any unusual symptoms. For the planning, the nurse should review the patient's history. It includes checking for blood type, history of transfusions, any previous transfusion reactions, checking allergies to ensure patient safety and minimize the risk of adverse reactions, and current health conditions, which can increase the risk of complications during a transfusion, are also essential part when reviewing patients' history. The nurse should confirm doctor's orders, confirm the number and type of units, including the desired speed of the infusion. This slide contains information on blood type compatibility and different blood products, which is essential in medical practice for safe blood transfusions. The first image is a blood type compatibility chart. The donor-recipient matching shows which blood types can donate to and receive from others. The universal donor is the O-negative, which can donate to all blood types, while the universal recipient is the AB positive, which can receive from all blood types. Remember that compatibility is crucial to avoid immune reactions during transfusion. The second image are the different blood products, in which we've discussed earlier with the indications. These are the components derived from donated blood, used in various medical treatments. Next is to plan the informed consent. It is essential for the nurse to explain the procedure, benefits, risks, alternatives to patient, empowering them to make informed choices based on their values, preferences, and understanding. Ensure informed consent is documented because it is a critical aspect of ethical, legal, and professional healthcare practice. The nurse should check for pre-medications. May require pre-medications to prevent allergic reactions. Note any pre-medication ordered by healthcare provider like acetaminophen or diphenhydramine, usually 30 mins prior to transfusion, because it helps prevent or minimize febrile, non-hemolytic reactions caused by the recipient's immune response to donor white blood cells, and reduces the risk of allergic reactions such as itching, rash, or mild hives. We should also plan the equipment preparation. The equipment includes unit of whole blood, PRBCs, or other component, blood administration set, IV pump if needed, 250 milliliters normal saline for infusion, IV pole, venipuncture set containing a number 20 to 24 gauge catheter if one is not already in place, alcohol swabs and tape, and clean gloves. Lastly, the nurse should verify the blood product. When verifying, confirm blood type and cross-match. Verify if blood type and RH compatibility match patient's needs to prevent hemolytic reactions. And double-check with another qualified healthcare provider. Follow hospital protocol for double-checking, patient identity, cross-match details with another professional to ensure accuracy. In implementation, the first thing we should do is to prepare the client. If client has IV solution infusing, check whether IV catheter and solution appropriate to administer blood. IV catheter size ranges between number 20 and number 24 gauge, and solution must be normal saline. Dextrose, which causes lysis of RBCs, Ringer's solution, medications and other additives, and hyperalimentation solutions are incompatible. But if client does not have IV solution infusing, check agency policies. Infusion must be running before blood is obtained from the blood bank. Perform venipuncture on suitable vein and start an IV infusion of normal saline. Let's start with the step-by-step process. Prior to performing the procedure, introduce self and verify client's identity. This step includes explaining to client what you are going to do, why it is necessary, and how to participate and understand. Instructing them to report promptly any sudden chills, nausea, itching, rash, dyspnea, back pain, or unusual symptoms. Next is to provide for client privacy and prepare client. The nurse should assist the client to comfortable position, either sitting or lying. Then, expose the IV site while still providing client privacy. Perform hand hygiene and observe infection prevention procedures. To prepare the infusion equipment, the nurse should apply gloves. Close all clamps on Y-set, main flow rate clamp, and both Y-line clamps. Insert piercing pin or spike into the saline solution. Then, hang the container on the IV pole about 1 meter or 39 inches above venipuncture site. After that, prime the tubing. When priming the tubing, open first the upper clamp on normal saline tubing, then squeeze drip chamber until it covers filter and 1/3 of drip chamber above filter. Tap filter chamber to expel any residual air in filter. Open main flow rate clamp, prime tubing with saline. Then close both clamps. Start saline solution. If IV solution incompatible with blood is infusing, stop infusion and discard solution and tubing according to agency policy. Attach blood tubing primed with normal saline to IV catheter and ensure the connection is secure. The nurse should open saline and main flow rate clamps and adjust flow rate. Remember to use only main flow rate clamp to adjust rate. Allow small amount of solution to infuse to make sure that there is no problems with flow or with venipuncture site. The reason of infusing normal saline before initiating transfusion is that it clears IV catheter of incompatible solutions or medications. Next is to obtain correct blood component for client. When doing that, check primary care provider's order with requisition. Then, check requisition form and blood bag label with laboratory technician or according to agency policy. Also, check the client's name, identification number, blood type A, B, AB, or O, and RH group, blood donor number, and blood expiration date. Observe the blood for abnormal color, RBC clumping, gas bubbles, and extraneous material. Note: return outdated or abnormal blood to the blood bank. Remember that with another nurse and the presence of the client, verify before initiating the transfusion. In doctor's order, check blood or components against written order. In transfusion consent form, ensure the form was completed by the patient. In client identification, the name and identification number on the client's identification band are identical to the name and number attached to the blood unit. In unit identification, the blood container, transfusion form, and tag attached to the unit must agree or match each other. In blood type, ABO group and RH type on the primary label of the donor unit must agree or be matched and recorded on the transfusion form. In expiration, the expiration date and time of the donor unit are acceptable. For compatibility, the interpretation of compatibility testing is recorded on the transfusion form and tag attached to the unit. And lastly, in appearance, there should be no discoloration, foaming, bubbles, cloudiness, clots or clumps, or loss of integrity of the container. This image is a detailed guide to interpreting the labeling on blood product packaging, specifically a unit of donated red blood cells. The label includes essential information to ensure proper identification, safety, and handling of the blood product. Remember, do not administer blood until discrepancies are corrected or clarified. Sign the appropriate form with another nurse according to agency policy. The nurse should make sure that the blood is left at room temperature for no more than 30 minutes before starting the transfusion, because as blood components get warm, the risk of bacterial growth increases. That is why, if the start of transfusion is unexpectedly delayed, it is better to return blood to the blood bank after 30 minutes. Note: do not store blood in the unit refrigerator, because the temperature of the unit refrigerator is not precisely regulated and the blood may be damaged. Next is the preparation of the blood bag. When preparing the blood bag, the nurse should first invert the blood bag gently several times to mix cells with plasma. Do not do rough handling because it can damage cells. Expose the port on the blood bag by pulling back the tabs. Then, insert the remaining Y-set spike into the blood bag. Do not forget to suspend the blood bag. Next is to establish blood transfusion. First, close the upper clamp below the IV saline solution container. Open the upper clamp below the blood bag. It will be visible that the blood will run into a saline-filled drip chamber. Squeeze the drip chamber to re-establish the liquid level with the drip chamber 1/3 full. Tap the filter to expel any residual air within the filter. The nurse should readjust the flow rate with the main clamp. Remove and discard gloves. Then, perform hand hygiene. The nurse should also observe the client closely for the first 15 minutes. Start transfusion slowly at 2 milliliters per minute for the first 15 minutes and remain near the patient to check any transfusion reactions. Increase transfusion rate if there are no signs of a reaction. This small amount is enough to produce a severe reaction, but small enough that it is possible to treat successfully. Note for adverse reactions like chills, nausea, vomiting, skin rash, dyspnea, back pain, or tachycardia. The earlier the transfusion reaction occurs, the more severe it tends to be. Always remind the client to call a nurse immediately if unusual symptoms mentioned are felt during the transfusion. The nurse should document relevant data such as the blood, vital signs, type of blood unit number, sequence number, site of venipuncture, size of catheter, and drip rate. Again, monitor the client 15 minutes after initiating the transfusion and perform vital signs monitoring. If no reactions occurred, the nurse should establish the required flow rate. Most adults can tolerate receiving 1 unit of blood in 1.5 to 2 hours only. Do not transfuse a unit of blood for longer than 4 hours. We should also reassess the client. If the client has a reaction and blood is discontinued, send the blood bag and tubing to the laboratory for investigation. Here are some transfusion reactions that can occur to a patient after a blood transfusion. Next is to terminate the transfusion. To do that, apply clean gloves first. If no infusion should be followed, clamp the blood tubing. If primary IV is to be continued, flush the maintenance line with saline solution. Disconnect the blood tubing system and re-establish IV infusion using new tubing. The nurse should adjust the drip to the desired rate. Normal saline or other solution should keep running in case of delayed reaction to blood. Then, do not forget to measure vital signs. Remember to document relevant data. The nurse should record the completion of the transfusion, the amount of blood absorbed, the blood unit number, and vital signs. If primary IV infusion was continued, record connecting it. Also, record transfusion on the IV flow sheet and intake and output record. For evaluation, always follow agency protocol for appropriate disposition of used supplies. The nurse should perform follow-up based on findings or outcomes that deviate from what is expected or normal for the client. If available, compare findings to previous data. Report significant deviations from normal to the primary care provider. For documentation, again, do not forget to record the completion of the transfusion, the amount of blood absorbed, the blood unit number, and vital signs. Transfusion on the IV flow sheet and intake and output record. Record starting blood, vital signs, type of blood, blood unit number, and sequence number, including the venipuncture site, catheter size, and drip rate. The last procedure we will discuss is the appropriate IV removal. For the assessment, the nurse should assess the appearance of the venipuncture site, any bleeding from the infusion site, the amount of fluid infused, and the appearance of a short peripheral catheter. For planning, the nurse should first assess the need for removal. ensuring that the physician or health provider has ordered the removal of the IV. Then verify the patient's condition. Check if the patient no longer requires IV medications or fluids, and assess if a peripheral or central line is still needed. The nurse should explain the procedure to the patient, informing them of the reason for removal, what to expect during the process, and any precautions. Then, prepare the supplies needed, such as clean gloves, gauze, antiseptic wipes, adhesive bandage, and sterile dressing. In the implementation, prior to performing the procedure, introduce yourself and verify the client's identity using agency protocol. Explain to the client what you are going to do, why is it necessary, and how to participate. Explain the reason for discontinuing IV and that the procedure should cause no discomfort other than removing the tape. Perform hand hygiene and observe other appropriate infection prevention procedures. Next, assist the client to a comfortable position, sitting or lying. Expose the IV site while providing privacy. Then, place the linen saver pad under the extremity with an IV. Prepare the equipment. Clamp infusion tubing to prevent fluid from flowing out of the needle onto the client or bed. Apply clean gloves. The nurse should remove the dressing and tape at the venipuncture site while holding the needle firmly and applying counter-traction to the skin. The reason for this is that the movement of the catheter can injure the vein and cause discomfort to the client. Doing counter-traction prevents pulling skin that causes discomfort. Use the appropriate solution, which is alcohol, to loosen the dressing and adhesive. Assess the vascular access site for signs of infection or phlebitis. Apply sterile gauze above the vascular access site with non-dominant hand. Only touch the upper portion of the gauze pad and maintain sterility of the lower portion that is in contact with the venipuncture site. Withdraw the catheter from the vein with the dominant hand. To do that, withdraw it by pulling it out along the line of the vein, using gentle, even pressure to avoid injury to the vein. Do not press down on the sterile gauze pad while removing the catheter. Immediately apply firm pressure to the site using sterile gauze for a minimum of 30 seconds or until homeostasis is achieved. The pressure helps stop bleeding and prevents hematoma formation. Then, hold the client's arm above heart level if any bleeding persists. Raising the limb decreases blood flow to the area. We should also teach the client to inform the nurse if the site begins to bleed at any time or client notes any other abnormalities in the area. These are the sample images on how to do it properly. Next, examine catheter removed from client. Check catheter to make sure it is intact, because if a piece of tubing remains in client's vein, it could move centrally toward heart or lungs. Remember, report broken catheter to nurse in charge or primary care provider immediately. If a broken piece can be palpated, apply a tourniquet above the insertion site to decrease the possibility of the piece moving until the primary care provider is notified. Next is to cover the venipuncture site. Apply a new sterile dressing to the site with tape because dressing continues pressure and covers open areas in skin, preventing infection. Discard used supplies appropriately. Remove and discard gloves. Then, perform hand hygiene. To facilitate proper sharps disposal, use appropriate puncture-proof disposal containers to dispose of uncapped needles and sharps. These are provided in all client areas. Remember that we never throw sharps in the wastebasket because sharps include any items that can cut or puncture skin, such as needles, surgical blades, lancets, and razors. It also includes broken glass, broken capillary pipettes, and reusable items like large bore needles, hooks, rasps, and drill points. Never bend or break needles before disposal. When recapping a needle, for example, drawing up a medication into a syringe before administration, use a one-handed scoop method. This is performed by placing the needle cap and syringe with the needle horizontally on a flat surface. Then, insert the needle into the cap using one hand. Pick up the cap and tighten it to the needle hub using your other hand. Be careful not to contaminate the needle. If the needle becomes contaminated, replace the needle with a new one. Place all needles, syringes, and sharps, like lancets, scalpels, and broken glass, into a labeled, puncture-resistant container approved only for this use. To avoid puncture wounds, use safety or needleless systems, and do not detach needles from the syringe or recap the needle before disposal. Here are the example images you could use to guide you when doing this step. For evaluation, perform follow-up based on findings or outcomes that deviated from expected or normal for the client. Relate findings to previous data available. For the documentation, the nurse should record the amount of fluid infused on intake and output record, and in the record, according to agency policy. Include container number, type of solution used, time discontinuing infusion, and client's response. Since we have sufficient knowledge about the preparation of IV insertion, blood transfusion, and IV removal, let's take a look at the actual demonstration for further understanding. In preparation for the IV, verify the doctor's order. Assess the patient's vital signs, bleeding tendencies, disease or injury to extremities, and status of veins. Determine if the client is right or left-handed. Introduce yourself and verify the client's identity using agency protocol. Explain what you're going to do, why it is necessary, and how to participate. Perform hand hygiene and observe infection prevention procedures. Open and prepare infusion set. Remove the tubing from the package and straighten it out. Slide tubing clamp along the tubing until it is just below the drip chamber to facilitate its access. Close clamp. Leave the ends of the tubing covered with plastic caps until the infusion is started to maintain sterility of the end of the tubing. Expose the insertion site of the bag by removing the protective cover. Remove the cap from the spike and insert the spike into the insertion site of the bag. Hang the solution container on a pole about 1 meter or 3 feet above the client's head. It is done to enable gravity to overcome venous pressure and facilitate the flow of solution to the vein. Partially fill the drip chamber with solution. Then, squeeze the chamber gently until it is half full of solutions. The drip chamber is partially filled with solution to prevent air from moving down the tubing. Prime tubing as described. Prime means to make ready, but in common use refers to flushing tubing to remove air. Remove the protective cap and hold the tubing over the container. Maintain sterility of the end of the container and cap. Release the clamp and let the fluid run through the tubing until all bubbles are removed. Tubing is primed to prevent air into the client, but air bubbles smaller than 0.5 liters usually do not cause problems in peripheral lines. Lastly, reclamp the tubing and replace the tubing cap, maintaining a sterile technique. Next is the IV insertion. Select venipuncture site. Use the client's non-dominant hand, unless contraindicated, like in clients with mastectomy and fistula. Look for veins relatively straight. The vein should look palpable, but may not be visible, especially in dark skin. When dilating the vein, apply a tourniquet 15 to 20 cm or 6 to 8 inches above the venipuncture site. The tourniquet must be tight enough to obstruct venous flow, but not so tight that it occludes arterial flow, because obstructing arterial flow inhibits venous filling. If a radial pulse can be palpated, arterial flow is not obstructed. Use a tourniquet on only one client to avoid cross-contamination with other clients. Also, ask the client if they have a latex allergy. If the vein is not sufficiently dilated, massage or stroke the vein distal to the site and in the direction of venous flow toward the heart, because it helps fill the vein. Clench and unclench fist, because contracting the muscles compresses distal veins, forcing blood along veins and distending them. Lightly tap the vein with your fingertips to distend the vein. If the preceding steps fail, remove the tourniquet and wrap the extremity in a warm towel for 10 to 15 minutes. Heat dilates superficial blood vessels, causing them to fill. Then repeat the steps to dilate the vein. If there is no venous site visible or easily palpated, use vein visualization technology to improve insertion success. Remove the tourniquet while preparing the insertion site. Apply clean gloves and clean the venipuncture site to protect the nurse from contamination caused by the client's blood. Clean skin at the site of entry with a topical, single-use antiseptic swab. The preferred antiseptic is chlorhexidine gluconate alcohol solution. Check allergies to iodine or shellfish before cleansing the skin with betadine or iodine solution. These are the cleaning techniques. In the circular motion method, apply antiseptic in a circular motion. Start from the cleanest area, which is the puncture incision point, and move outward to the periphery. Avoid reapplying the same compress to any area to prevent recontamination. While in the back and forth technique, move around the insertion point and impregnates cracks and crevices. Reapply the tourniquet above the intended venipuncture site. If vein palpation is necessary, after the application of skin antiseptic, use sterile gloves. Remove the catheter from its sterile packaging. Remove the cover of the needle. Use a non-dominant hand to pull the skin taut below the entry site, because it stabilizes the vein and makes the skin taut for needle entry. Make initial tissue penetration less painful. Holding over the needle catheter at a 15 to 30 degree angle with the needle bevel up, insert the catheter through the skin and into the vein. A sudden lack of resistance is felt as the needle uses slow, steady insertion, avoiding jabbing or stabbing motion. Once blood appears in the lumen or flashback chamber of the needle, lower the angle of the catheter until almost parallel with the skin, and advance the needle and catheter to 0.5 to 1 centimeter or 1/4 inches farther vein. Release the tourniquet while stabilizing the catheter by applying gentle but firm pressure with a non-dominant hand, approximately 3 centimeters above the site. It prevents excessive blood flow through the catheter. Stabilize the catheter and apply dressing. If the tape is used, it must be sterile tape or surgical strips, and they should be applied only to the catheter adapter and not placed directly on the catheter skin junction site. Carefully remove the stylet, then place the stylet directly into the sharps container. Remove the protective cap from the distal end of the tubing and hold it ready to attach to the catheter, maintaining sterility of the end. Stabilize the catheter hub and apply pressure distal to the catheter using your finger. It prevents excessive blood flow through the catheter. Loop the tubing and secure it with tape. Looping and securing the tubing prevents its weight or any movement from pulling the needle or catheter. Discard tourniquet. Remove and discard gloves and perform hand hygiene. Ensure appropriate infusion flow. Adjust the infusion rate of flow according to the order. Label IV tubing with the date and time of attachment and your initials. Tubing is labeled to ensure that it is changed at regular intervals. Next is the demonstration of blood transfusion. Prior to performing the procedure, introduce yourself and verify the client's identity. Explain to client what you are going to do, why it is necessary, and how to participate, and instruct them to report promptly any sudden chills, nausea, itching, rash, dyspnea, back pain, or unusual symptoms. Perform hand hygiene and observe infection prevention procedures. Prepare infusion equipment. Apply gloves. Close all clamps on the Y set, the main flow rate clamp, and both Y-line clamps. Insert the piercing pin into the saline solution. Hang the container on the IV pole about 1 meter or 39 inches above the venipuncture site. Prime tubing by opening the upper clamp on normal saline tubing, then squeezing the drip chamber until it covers the filter and 1/3 of the drip chamber above the filter. Tap the filter chamber to expel any residual air in the filter. Open main flow rate clamp, prime tubing with saline. Then, close both clamps. Starting the IV line. After starting an IV line, prepare for blood transfusion. Obtain correct blood component for client. Check client's name, identification number, blood type if A, B, or O. Check the RH group, blood donor number, and the expiration date of blood. Observe blood for abnormal color, RBC clumping, gas bubbles, and extraneous material. Return outdated or abnormal blood to blood bank. With the presence of another nurse and client, verify before initiating transfusion order. Check blood or component against written order. Ensure that the transfusion consent form had been completed. Identify the client using their name and identification number from their identification band, ensuring that the name and number attached are identical to the blood unit. Check unit identification, the blood container transfusion form and tag attached to unit must agree and match each other. Blood type, ABO group and RH type on primary label of donor unit must agree recorded on transfusion form. Check for the expiration date and time of donor unit and if it is acceptable. Ensure that the interpretation of compatibility testing was recorded on transfusion form and tag attached to unit. There should no discoloration, foaming, bubbles, cloudiness, clots, or clumps, or loss of integrity of the container. These are the pieces of information that should be attached to the blood bag. Make sure blood left at room temperature for no more than 30 minutes before starting transfusion. As blood components warm, risk of bacterial growth increases. If start of transfusion is unexpectedly delayed, return blood to blood bank after 30 minutes. Do not store blood in unit refrigerator and the blood may be damaged. Prepare blood bag. Invert blood bag gently several times to mix cells with plasma. Expose port on blood bag by pulling back tabs. Insert remaining Y-set spike into blood bag. Close upper clamp below IV saline solution container. Suspend blood bag. Open upper clamp below blood bag. Squeeze drip chamber to re-establish liquid level with drip chamber 1/3 full. Tap the filter to expel any residual air. Connect the blood tubing into the primary IV line. Readjust flow rate with main clamp. Remove and discard gloves. Then, perform hand hygiene. Observe client closely for first 15 minutes. Start transfusion slowly at 2 milliliters per minute for first 15 minutes, and remain near patient. Increase transfusion rate if there are no signs of a reaction. This small amount is enough to produce a severe reaction, but small enough that the reaction could be treated successfully. Note adverse reactions like chills, nausea, vomiting, skin rash, dyspnea, back pain, or tachycardia. The earlier transfusion reaction occurs, the more severe it tends to be. Remind client to call a nurse immediately if unusual symptoms felt during transfusion, like chills, nausea, itching, rash, dyspnea, or back pain. Document relevant data like blood, vital signs, type of blood, blood unit number, sequence number, site of venipuncture, size of catheter, and drip rate. Monitor client 15 minutes after initiating transfusion, vital signs. If there are no signs of a reaction, establish the required flow rate. Most adults can tolerate receiving 1 unit of blood in 1.5 to 2 hours. Do not transfuse a unit of blood for longer than 4 hours. Reassess client. If client has reaction and blood is discontinued, send blood bag and tubing to laboratory for investigation of blood. When terminating the transfusion, apply clean gloves. If no infusion is to follow, clamp blood tubing. If primary IV to be continued, flush maintenance line with saline solution. Disconnect blood tubing system and re-establish IV infusion using new tubing. Adjust drip to desired rate. Normal saline or other solution should keep running in case of delayed reaction to blood. Then, measure vital signs. Document relevant data. Record completion of transfusion, amount of blood absorbed, blood unit number, vital signs. If primary IV infusion was continued, record connecting it. Record transfusion on IV flow sheet and intake and output record. Last is the demonstration of IV line removal. First, assess the appearance of the venipuncture site, any bleeding from the infusion site, the amount of fluid infused, and the appearance of a short peripheral catheter. Prior to performing the procedure, introduce yourself and verify the client's identity. Explain to client what you are going to do, why it is necessary, and how to participate. Perform hand hygiene and observe infection prevention procedures. Remove dressing and tape at the venipuncture site while holding the needle firmly and applying counter traction to the skin. Movement of the catheter can injure the vein and cause discomfort to the client. Doing the counter traction prevents pulling skin that causes discomfort. Use an appropriate solution like alcohol to loosen the dressing and adhesive. Assess the vascular access site for signs of infection or phlebitis. Apply sterile gauze above the vascular access site with a non-dominant hand. Only touch the upper portion of the gauze pad and maintain sterility of the lower portion that is in contact with the venipuncture site. Withdraw the catheter from the vein with the dominant hand. Withdraw the catheter by pulling it out along the line of the vein using gentle, even pressure. Pulling it out in line with the vein avoids injury to the vein. Do not press down on the sterile gauze pad while removing the catheter. Immediately apply firm pressure to the site, using sterile gauze, for a minimum of 30 seconds or until homeostasis is achieved, because pressure helps stop bleeding and prevents hematoma formation. Hold the client's arm above heart level if any bleeding persists, because raising the limb decreases blood flow to the area. Then, teach the client to inform the nurse if the site begins to bleed at any time, or client notes any other abnormalities in the area. Examine the catheter removed from the client. Check the catheter to make sure it is intact. If a piece of tubing remains in the client's vein, it could move centrally toward the heart or lungs. Report the broken catheter to the nurse in charge or primary care provider immediately. If the broken piece can be palpated, apply a tourniquet above the insertion site. Application of a tourniquet decreases the possibility of the piece moving until the primary care provider is notified. We're done. Thanks for listening, and I hope you have learned something today.